Welcome, everyone. I'm your host, Dr. Randall Wolf. This is DeBakey CV Live, the first Tuesday of the month. We cover arrhythmia procedures, and this is no exception. We will be discussing the Minimaze procedure before and after. Our guest is Mr. Brad Glass. He's from Eagle, Idaho. He's been kind enough to join us this evening. Brad, welcome to the program.
Afternoon, Dr. Wolf. Thanks for having me.
You're welcome. Our producers today are George and Fernando, and we're coming to you as a result of DeBakey CV Live, which was put together by our leader, Alan Lumpson, who's the chair of the department and head of DeBakey Heart and Vascular Center. You will be seeing from time to time a screen that shows you a way to ask us a question. The question can be for Brad or for me or for both of us. It's on your screen now. Thank you, George and Fernando. You'll see if you're on your phone, you can send a text. The number's there, 37607. And then in the box, you put DeBakey, and that will hook you up and you'll be able to ask your question. We try to get to all questions during the hour. Sometimes we have a lot, but we try to get through them. So if you put your question in, be a little patient and we'll get to it. Or if you're on a laptop, you can go to pollev.com, you enter DeBakey, and then you respond and you'll be able to type in your question or comment, either one, to either me, Dr. Wolf, or Brad Glass. Now, the reason that we're doing before and after is to bring up a particular issue that I have encountered many times. And I figure if I've encountered it many times, it's probably been missed many times as well. And Brad's history sort of fits in with this issue. And there is a solution to it, but I guess not everybody knows about it. So I thought it'd be a very important thing to cover. At the same time, Brad will cover sort of the pre-Minimaze journey he was on, and then also the post-Minimaze journey. Brad is about 4 months after the Minimaze procedure at Houston Methodist, and he can tell us about that. So if you have questions about the procedure, about what he had done, about his history, or questions for me, or your particular situation, then go ahead and either send us a text on your phone or go on the laptop to pull EV. We'll spend about 45 minutes on this topic. We'll try to answer all your questions as well. Brad, again, thanks for joining us on the program. And usually the best way to start a program like this is to start your journey at the beginning and give our listeners a little intro into how your problem started and how it proceeded.
So it was at least a good 2 years ago. I had actually I was up on vacation and I wasn't feeling good in the middle of the night. I mean, I thought maybe my blood pressure medicine was off or something. And so I actually drove 2 hours down from northern Idaho down into the Boise ER. And that's when I was diagnosed with AFib. And so setting up an appointment, trying to find a cardiologist in the city of Boise, and got a hold of a alleged AFib specialist, and basically gave me my options. There's basically 5 options for the most part. Option 1 is to do nothing. Option 2 basically is meds, which they started me on right away, the blood thinners and heart rate meds. And they can do try to stop your heart to get your heart back in rhythm, or
the cardioversion.
Yes.
Mm-hmm.
Or they can do the arterial ablation. So that was scheduled within 30 days.
I think they left one option out.
What's that one? The Minimaze.
Yeah.
They did. They didn't know about the Minimaze, unfortunately, and I didn't either, but I do now. So then I had my first, about within 30 days of that visit with my cardiologist, and I had an attempted arterial ablation. And when they got in there, they had put me under, and they did a scoping, and where they take the ultrasound down the esophagus and down behind the heart. And the purpose of that is to see if you have a blood clot, which I had not even been told anything about that until after that first failed attempt, when he told me, oh, well, you were seeing a blood clot in that appendage in your heart. And so we couldn't proceed.
Okay, let me interject this
Okay,
here for a
go ahead.
minute. So it is standard procedure to do a transesophageal echo, also
Correct.
known as the TEE,
Correct.
before starting the catheter ablation. And the purpose of that is to look at the anatomy, but also to assure them that there's no blood clot in the left atrial appendage. In atrial fibrillation, 97% of all the blood clots are in the appendage. Now, if there is a blood clot in the appendage, there's a fear that shocking the heart in and out of rhythm during a catheter ablation could break that blood clot loose. If the blood clot cuts loose in the atrium, it will usually travel through the mitral valve into the lower chamber, the left ventricle, and from there be pushed out into the aorta. The first three branches of the aorta go to your brain. So there's a high likelihood if a clot leaves the heart, it will go straight up into the brain on one of those first three branches. A blood clot lodging in the brain starves the brain of blood, and within a short period of time, sometimes only 3 to 5 minutes, a stroke can begin as neurons start to die, the cells in your brain start to die. And AFib strokes tend to be rather catastrophic. So there's a big fear, and the first thing that's done is, well, let's make sure there's not a blood clot in the left atrial appendage, which, by the way, is something that I've always closed with the Minimaze, so you don't have to worry about blood clots the rest of your life after a Minimaze, at least not a blood clot in the appendage, because it's closed. It is possible that the blood clot leaving the heart will not go into one of the arteries in the brain, to go to the brain, and would then go down to the arm or leg. And the symptoms are acute coldness of a hand or a foot. And we sometimes see that, but most of the time that blood clot will go up into the brain. So in Brad's situation, when you woke up, they said, we think there's a blood clot in the appendage, therefore we cannot proceed. Is that correct?
That's correct. Okay, so after the first failed attempt, 3 months later, they put me on baby aspirin, and I was on Eliquis. Actually, I was originally on Xarelto. And then after they figured I had this, they put me on Eliquis and a baby aspirin. And then after that, there was 4 after the 4th attempt, which then was after the first of the year. They put me on Panics, took me off the baby aspirin, and they tried 2 more attempts. And so on the 6th final attempt last August, he told me that when he brought me out, he goes, you still have a blood clot in your heart. He goes, I need to put in a pacemaker. And my concern was to him, I said, when I talked to you last year, that was one of my specific questions was, is mine pacemaker related? And now you're telling me that I need a pacemaker. So what does that do for that blood clot in my heart? And he couldn't give me an answer. And then shortly after that, that's when I found I think it was even on Facebook. I was on Facebook, and AFib, stopafib.org came up, and they talked about the organization, about the different procedures, the medication, the different doctors, just all kinds of stuff. And that was last year, Halloween week, which I attended the Zoom, and it was, I'll tell you what, it was $49.95, and it was the best $49.95 I'd spent in my life. I can tell you that right now. But there was about a 3 or 4 day, and I actually got to talk to you briefly. And it wasn't until after that, and I'd sent you an email, and I just gave you basically what I told you, that, is there anything you can do for me? And with that, what can you tell me about this blood clot in my heart? And you wrote back in 4 words in an email, I can help you. And that was all I needed. And from that, we set up a Zoom. And then the first schedule for my Minimaze was actually in February 18th, around in there. But that was when Texas had their deep freeze and things got kind of shut down. Even the airlines, even my airline actually canceled my flight. And so then I rescheduled and went down in May. And I was down there on a Monday afternoon. I had a CT scan with nitro. And then on Tuesday morning, I had a EKG. And then I met with you on Tuesday at noon. And one of the things you said, well, I got some good news. You don't have a blood clot in your heart. And we got into that conversation, is the one thing you asked, had they ever done a CT scan with, even a CT scan period, but with nitro? And I said, no, that was always just that scan. And so then the procedure was on Wednesday morning. I was in OR for Wednesday night, went to regular hospital room Thursday morning, stayed Thursday night, was out Friday afternoon, walking the Houston Zoo on Saturday afternoon. So
Brad brings up, as I said, a situation I've seen many times, and that is the transesophageal echo, or echo where they put the probe down your mouth, is not a great way to tell whether or not there's a blood clot in your heart. It's okay, but it's not great. And let me give you an example. The appendage sometimes looks like a sock, the end of where the toes are. And sometimes that sock folds over on itself. So that instead of the end of the sock sticking straight up, the tip folds over. And when that happens, it gives a double density. So if you have a sock like this, and then the top folds over, it looks like this. Now there's no blood clot in there, but if you look at it like this, it looks like there might be a blood clot there. When really all it is the appendage has folded over on itself. And most electrophysiologists and cardiologists don't understand that. Why don't they understand it? Because they've never seen an appendage in the flesh. They've only seen the echo image of this. So nobody ever corrects them and tells them that that's not a blood clot. It's simply appendage that's folded over. So they never get any clinical correlation. One of the advantages of being a surgeon is we can look at all these studies that are done before a procedure, but then we get to see what actually is there. And it's not the same as the radiologist or the cardiologist always calls it, but they've never seen it. They've never seen the appendage. I'd say almost all the cardiologists in the world have never seen a real appendage beating in a heart. So that's the difference. But I know that, and I've seen that scenario. We had, this was many years ago, I sent a patient, and I was told that they definitely had a blood clot in their heart, and they would not allow me to do anything but open heart. And the patient bought into that. So we did open heart. We did a full maze, open heart through the breastbone, looked in the appendage. Guess what? No blood clot. There never was a blood clot there. It was just folded over in a funny way. Sometimes the appendage can have 4 or 5 fingers, and sometimes 2 of the fingers will be folded over. It'll look like a blood clot, but it's not. So I learned early on that we needed a better test than a transesophageal echo to determine if there truly is a blood clot in that little ear of the heart. Now, a long time ago, the appendage used to be called the appendix of the heart because it looks like an appendix and it acts like an appendix. It's not something that you need anymore. The appendage early in development before we're born is the back of the heart. But as the pulmonary veins grow into the heart, that back of the heart moves over to the side and becomes the appendage. So you don't need it as an adult. You don't need it as a child. But we needed a better test to see if really there was a blood clot in the heart. So I did a series of patients where we did CT scans and we also did MRI scans, magnetic resonance scans. We have a question here. I'll leave that question up there. I'll get to it right in a minute. So I said, let's do a CT scan with contrast. And guess what? That was variable also. Sometimes the appendage does not fill with contrast when the heart is out of rhythm because that blood is moving so slowly that the contrast doesn't fill that part of the heart until the study's over. So the study's over and that part of the heart's not filled with contrast yet. So we came up with an algorithm. We published this in a radiology journal probably 12 years ago. And it was called the 1 minute solution. And we take a delayed scan of the CT scan. It was called the 60-second solution. 60-second solution, you take a delayed scan and then you see that the appendage is filled. So if you follow this with me, when the heart's in AFib, the top two chambers are not beating. They're just shaking like this. And blood stagnates. Of course, that's why you can get a clot there. The blood stagnates. And in any animal, whether it's a pig or human or dog, if you let the blood stagnate too long, it'll clot. It'll clot in your heart. It'll clot in your leg. It clots in your leg. It's called a deep venous thrombosis, DVT. If it clots in your appendage, it's called an atrial thrombus. So the blood's not moving very fast in AFib at all. And you give contrast, and if you don't give it long enough to circulate, you'll say, oh, there's a blood clot in the heart because the contrast didn't get there. But it didn't get there because you didn't give it enough time. So we came up with the 60-second solution. That's what they do for every CT scan for me pre-op for Minimaze. It's the Wolf protocol. And essentially, there's a little bit more to it, but essentially, it's a delayed scan that will allow enough time for that appendage to fill. And that pretty much has ruled out all these, what we call false positives. That means, in your case, Brad, they said there was a clot there, but in fact, there wasn't. So the positive test was false. And we can get rid of all those simply by doing a CT scan with delayed images. Let's take this question and then we'll get back. What effect does Minimaze have on heart rate variability? Okay, not completely related to what we're talking about, but let's go ahead and take that question. It's a good question. And then another one, is the Minimaze appropriate if you're being told you need an ablation for the first time? Oh, another good question. Let's take the second question first. Is the Minimaze appropriate if you're being told you need an ablation for the first time? In almost all cases, the answer is yes. One of the most common complications of a catheter ablation is atypical left atrial flutter. And I talked to 2 patients today on the phone from other parts of the country who have left atrial flutter. This is a complication of a catheter ablation. We can get rid of that with the Minimaze, but it's not so easy. If a patient has not had an operation on their heart, then it's so much easier to do the Minimaze and to get a good result because the inside of the heart has not been scarred. And this goes to the basic difference between catheter ablation and Minimaze. I have a fundamentally different approach to AFib. It's based on the fact that AFib probably starts from the vagus nerve. And that's those little branches of the nerve are on the outside of the heart, not the inside of the heart. So it makes no sense to me to burn up the inside of the heart, which only has muscle, no nerves, when the problem is on the outside of the heart. And burning up the inside of the heart results in another arrhythmia, which is called flutter. And most patients who have atrial flutter tell me they wish they had their old AFib back. So it's much easier and the results are much better if a Minimaze is performed before a catheter ablation. In today's world, about half of my cases are first timers, half are people that have already had failed ablations, anywhere from 1 all the way up to, yes, 7. But it's much easier if they haven't had. Now, sometimes it's an insurance situation. It depends on insurance. Medicare doesn't care if you've had 0 ablations or 20. Minimaze is fine. Other private insurers fall somewhere in between. The second question was on heart rate variability. After the Minimaze, because we've done a partial cardiac denervation, the heart rate tends to stay pretty steady and usually about 10 to 20 points higher than it was before the Minimaze. That's if the patient has not had a previous ablation. If there have been previous ablations, it's hard to predict. But with no previous ablations, usually the heart rate is about 10 to 20 points higher, and it may stay that way for 3 or 4 months, which is fine. Because usually if that happens, you don't have AFib anymore. At what point, here's another question, at what point has someone had too many ablation attempts to have a successful Wolf Minimaze procedure? That's a good question. And it says question 4, question 5. And there's a funny answer to that. It's a joke. And that is, well, it depends on how many children the electrophysiologist has in college at the time. But that's not the right answer. The right answer, we don't know. In my experience, I think 1 or 2 ablations is enough to say that this approach probably won't work. And there's another way to look at this. I ask patients who come to see me, okay, you've had 4 ablations. Are you still on an antiarrhythmic? Yes, I am. Are you still on a blood thinner? Yes, I am. Are you still having AFib? Yes, I am. I said, are you really better off than before you had the ablations? Some people will say, well, I have not as often. Other people say, no, I'm the same as before. So how many times does it have to be done before you figure out you're probably not going to get a good result? Now, keep in mind, we're talking about atrial fibrillation. Atrial flutter is a different animal. And initial atrial flutter is much better treated with a catheter ablation and not surgery. But in my opinion, and I'm biased, I believe that the Minimaze is the first choice, is a good way to go. I take care of a lot of pilots, and pilots get grounded when they have AFib. They want a one and done procedure. They do not want to be on medications. They do not want to be on blood thinners. So for most of the pilots, they go straight to the Minimaze and avoid the multiple ablations first. So the point of this, of Brad being here is to show you and suggest to you that if you've been told you have a blood clot in your heart, you have to ask the question, what have you done to show the blood clot? If the answer is only an echo or a transesophageal echo, that's not enough. And most of those are false positives. Brad I guess you went back to the cath lab 6 times total, right?
Correct, in a year, yes.
In a year, screwing around when really there wasn't a blood clot at all. Thank goodness there wasn't.
Definitely.
But in fact, blood clots seen in the heart during a catheter ablation are pretty rare, but false positives are not rare. We got some more questions here, but we'll get to your questions. I want to get back to Brad for a minute. You're now 4 months after surgery. You were on 2 blood thinners before surgery. Were you on any other medications that you recall?
No, I just my blood pressure medicine. And
okay. And another good thing is what we found over the years is your blood pressure is often much better controlled after a Minimaze. So we usually get patients off their blood thinner after a off their blood pressure medications after a Minimaze. Well, the first thing we do is cut them in half. How about your situation, Brad?
Yes, that's where we're at. Yep. You've cut mine in half and I'm off. I've cut, of course, I'm not on blood thinners at all. And because I was an AFib for as long as I was, basically my heart rate med is cut in half. I'm down at 120 mgs now, but I feel stronger every day. I mean, I walk 2 to 3 miles every other day. I feel stronger every day. I feel like I'm 20, basically. I'm telling you. Yes. I don't look like I'm 20, but I feel like I'm 20.
You look really good. But you bring up a good point. I've heard that comment many times. It took me years to, I think, figure it out. Because people would say, I feel 20 years younger. And I'm thinking, okay, you're back in rhythm, you're not having AFib. But this is even more. And what I think it is, it's 50% of it is staying in rhythm and not having that time bomb hanging around your neck, not knowing when your next episode is going to be. And God forbid it's when you're in a meeting or you're on a plane or you're hiking somewhere in Idaho, you're worried about that. But
Exactly.
I think the other half is you get off medicines. And
Definitely.
if you didn't have AFib a long time, but the longer you have AFib, the more medicines you tend to be on, and the doses tend to be higher. And it may start out with sotalol at a low dose, and then it's doubled, and then it's doubled again. And a lot of people who are on these higher doses of medicine are so tired by noon, they're on the couch. So I think it's a combination of getting in rhythm and also getting off the medications. And I think when people want to contrast the Minimaze procedure, one and done, with a catheter ablation, they should also consider, can I get off my medicines? And it's less likely with a catheter ablation. And a lot of patients after a catheter ablation are told you still can't drink coffee, you still can't have a glass of wine, you still can't have 2 beers. After the Minimaze, the whole idea is you can live your life. So you can have a glass of wine, you can have 2 beers. Those triggers are gone. They're gone.
Definitely.
So it sounds like you have not had any AFib. We used a link too, did we? I think we put a link
Correct.
in, didn't we?
Yes, I do. I have the link in. I do.
And I think that's been clean as a whistle, right?
Yes.
So for those in the audience not familiar with this, it's LINQ. It's a subcutaneous device. That means it's put in under the skin. And Brad, I put it in the office a week after surgery. It's a local anesthetic. It's a modified syringe that shoots this little device under the skin on your chest, about right here. And it allows a signal to be sent a few feet away to where I can see Brad's EKG every day. So his EKG from today, I'll see tomorrow. It also gives us a running total of the amount of AFib that a patient has. So it can say you're an AFib 5% of the time or 10% of the time this month. Brad's is 100% normal sinus rhythm. AFib burden, it's called the burden, is 0. And that's what we want to see. And I don't know, I'd like to get your opinion. A lot of patients will say having that device there gives you some peace of mind.
You bet. I mean, it's, I guess I'd call it a backup system, but it's just knowing that it's there. And I think we talked about, how long that battery lasts in that unit, and 4+ years. And I asked you, well, what do they do after that? And he said, well, 90% of them basically want it replaced just because of what you talked about, just the reassurance for the most part. But it's, you don't feel any of that, of course. And I just can't describe how, of course, when I first heard of your procedure, watched the the Zoom, the webinar, there was no hesitation for me. I mean, I couldn't get in to see you fast enough. It was just too bad that I was in Idaho and you were in Houston, or I'd have been knocking at your door the next day for sure. And it was a real heartbreak after in February when you had that weather system and it shut things down. And I couldn't go, I can't tell you what a heartbreak that was, because for over a year being told that I had that blood clot in my heart, the mindset that you have, it's like being told, okay, you've got pancreatic cancer, you got 4 to 6 weeks to live, because you feel like you're a walking time bomb. So your whole mindset, but you got to remain positive. Don't get me wrong. That's the one thing I can tell all your patients to be, and patients now and patients after. You got to have, you got to be patient with stuff, and you got to have the right mindset. This is something that, like I said, there was no backing out. It was something I had to proceed to do, because one of the things is it was the best answer that I'd gotten. And I was working with 3 seasoned alleged cardiologists in the Boise Valley.
Yeah,
So
yeah. Let's take a few more questions, Brad. I have AFib, and because I also have AVMs, that's arteriovenous malformation. It's a situation where the arteries and veins touch each other. So my EP, that's the electrophysiologist, said I can't take blood thinners. Would I be a candidate for the Maze procedure? Absolutely. One of the strong indications for performing the Minimaze is to make it safe for you not to have to take blood thinners. Even if the heart is out of rhythm after the Minimaze, you don't have to take blood thinners anymore, because the risk has decreased so much. A blood thinner, including the newer ones, decrease the risk of AFib stroke by 60%. I think a lot of people take these blood thinners and think they're 100% protected from AFib stroke. It's not the case. We see patients every week who have strokes on blood thinners. So it decreases the risk by 60%. The Minimaze decreases the risk of AFib stroke by 97%. And you don't have to take blood thinners anymore. If the blood thinner can make your blood too thin, and you can have a hemorrhagic stroke too. So it's blood thinners can lead to a complication. What is the status of elective surgeries at Houston Methodist? Okay, we were unscathed by the latest pandemic Delta surge up until just 2 weeks ago, because generally my patients do not go to the ICU anymore after Minimaze. We developed another unit. It's a regular floor, but the rooms have monitors in the rooms, so we don't go to the ICU anymore. So we were unscathed, but the combination of the Delta surge, a nursing shortage, has led Methodist to ask me to stop the elective surgeries for a couple weeks. My understanding is at least, or no, not at least, but maybe 1 more week, and then we'll be back up and running. The good news is they have guaranteed me another room for another day of the week. So we will be able to perform more cases with guaranteed start times once we're up and running. But it looks like elective surgeries are off for about another week at Houston Methodist. Now, this is a fluid situation, and I read a book not too long ago called The Great Pandemic. If any of you want a great book to read, The Great Pandemic was published probably 6 or 7 years ago. It's not about this pandemic. It's about the pandemic of 1917, 1918. That was, many of you probably heard about this. It was about 100 years ago. It was when the United States was in the Great War, World War I, as we know it now, but at that time it was called the Great War. And that pandemic probably started in the United States, and it killed more US soldiers than any battles. Young men were dying right and left, 20, 22 years old. they were doing fine one day and they were dead the next. The barracks were filling up with dead soldiers. What did they have a shortage of? Nurses. And the same thing has happened now. We have a shortage of nurses, big time. So it's not only a lot of patients in the hospital with COVID, it's also a staff shortage. So it's an interesting book, The Great Pandemic. You can get it on Amazon. Really interesting read to see the parallels. Now, this author finished this book 7 years ago. One of his predictions in the book was not that if, but when the next pandemic comes, he said there might be a shortage of ventilators. How about that? He made that prediction when he wrote that, it was probably 8 or 9 years ago. Very interesting. And the big shortage was nursing.
I can tell you that when I was down at Houston and I was under the utmost care. I mean, I can't tell you how pleased I was with that. I mean, it's just, there's anybody in that area that hasn't heard of Dr. Wolf's Minimaze, I can tell you. I mean, I'm walking the Houston Zoo on Saturday from the Wednesday procedure, right? And I'm in a gift shop because my significant other's merchandise for gifts. And I'm here a couple of younger gals talking, and I went over and asked them a question, and they were looking at me, and I don't know how it came up, but I just said, yeah, I had just had a heart procedure. And the one gal goes, Dr. Wolf's Minimaze? And okay, so there's what, 29 million people in Texas, and what, I mean, what are the odds of that? I mean, it just, I couldn't get over that. I'm sorry. It just,
Well,
I had to bring
that
up. I had to bring that
there are
up.
about 6 or 7 million people in Harris County, which is Houston. Okay, producers got us going again. Please discuss Wolf Minimaze versus Convergent procedure. Another one is someone has paroxysmal AFib and a history of pulmonary emboli with a high CHAD score. Is it likely that anticoagulant therapy can be stopped post Minimaze? And then if your AFib gets triggered by eating, it sounds like the Minimaze probably would help. We'll take all these questions. The bottom one is if your AFib gets triggered by eating, sounds like the Minimaze may help. That is true. We've had many patients who've had both AFib and a stomach issue, and generally they tell me the issue is resolved after the Minimaze. Now, the vagus nerve gives off these branches, thousands of them, to the heart. We're working on the nerves that are around the left atrium, and specifically the pulmonary veins. Guess what? That's where the cardiologists do the burning, but they're on the inside and the nerves are on the outside. But these nerves then go to the stomach. So oftentimes we have very happily for the patient solve their stomach problem when we do the Minimaze. If someone has paroxysmal AFib and a history of pulmonary emboli, a high CHAD score, the CHAD score is a score that suggests that whether or not you should be on a blood thinner based on your age and whether you have heart failure and different things and high blood pressure. Is it likely that anticoagulant therapy can be stopped after Minimaze? Yes, I would say yes. And I've done many patients who've had previous pulmonary emboli. We do a CT scan pre-op, as we talked about with Brad. One of the advantages of that scan is we not only see whether or not there are any blood clots in the heart, we also see if there are any blood clots in the lungs. So if that looks pretty clean, then after the Minimaze, we would not keep the anticoagulant, maybe for a month or two, and then stop it. Please discuss the Wolf Minimaze versus Convergent procedure. Okay, this is an interesting question. I'm glad whoever put that in there asked that. It's a very good question. And I'll say right up front, I'm not a big fan of the Convergent procedure. I did a Convergent procedure in Europe about 12 years ago. And the problem is it's just kind of carpet bombing the outside of the heart, but it's not directed. With the Minimaze, we test these nerves, we ablate these nerves, and it's very clean. I now have had the, I won't say it's a privilege, I'll say it's the opportunity to go in on some patients who've had a convergent procedure, which failed, and then along with catheter ablations, then they asked me to go in and fix it. It is a mess. It's almost impossible to do a Minimaze after a catheter ablation. I did one on a fellow from Southern California a couple of months ago, and I did get it done. He has no more AFib at all. So he's doing great, but it's one of those procedures that's so difficult that the patient can go to the floor, but the surgeon has to be admitted to the ICU. So it's not a very easy procedure to try to do a Minimaze after a convergent. The other problem with the convergent procedure, in my mind, is it still relies on the catheter ablation to do part of the work. But if the problem's not on the inside of the heart and it's the outside of the heart, why would you rely on a catheter ablation to get a good result? So I think the premise of the convergent procedure is a little skewed. It's skewed towards saying a catheter ablation is good, but the cardiologist doesn't want to burn the back of the heart where the esophagus is. So we'll let the surgeon burn the bejesus out of the back of the heart, then we won't have to go to the back of the heart and everything will be fine. But you're still depending on a catheter ablation for a good result. And I think that's part of the downfall of the procedure. Secondly, it does not address the ganglionic plexi. That's what starts the AFib. That's vagal AFib. And thirdly, it does not, at least in the study that was done, does not include closing the appendage. Closing the appendage is of paramount importance. Number one, it eliminates the possibility of stroke and you don't have to take blood thinners anymore. Number two, it electrically isolates the appendage. So if the AFib was coming from the appendage, it will cure it. Now, if you look at the Watchman device, the Watchman device is more of a cork that's stuck into the appendage. It does not electrically isolate the appendage. So the appendage can still be the source of AFib. The Watchman won't stop that. So for all those reasons, I'm not a big fan of the convergent procedure. And I would say if you're leaning towards a convergent procedure, at least discuss with me the Wolf Minimaze. And after you discuss it with me and you decide you'd rather have the convergent, that's fine. But I think you should at least look closely at the other options beside a convergent. I have not been favorably impressed. Here's a quote. I had the Minimaze with you on August the 2nd, and my stomach problem is gone. I'm able to eat again. Please share. Thank you, Dr. Wolf. But thank you so much for tuning in, since you've already had the procedure, giving that great comment. Now that could be good and bad. Being able to eat again could be good, but it could also be bad for some of us that are a little bit overweight, but that's a whole nother issue. So I think we covered those three questions. Let's go back to Brad. To me, as a physician, the one thing that bothers me the most is that many times patients don't know all their options. And I think this happened to you, Brad. I think you assumed you were given all your options when in fact you weren't. And the one option you were given, which was to put a pacemaker in, usually includes an AV node ablation. That means they wipe out your own pacemaker. You're dependent on a pacemaker. And guess what? It doesn't treat your AFib. It just treats your heart rate. Now, what would be your advice to people after what you've gone through as to trying to sort things out?
You've definitely got to do some research on your own. You've got to look out there. You've got to talk to people. You've got even on the website MedMD, there were several people that had made comments how they had lost loved ones from failed attempted ablations from, like you said, burning the backside of the heart and stuff. Mm-hmm. I can't tell you finding, and even, I mean, you see, it's just like with the Watchman. You talk about the Watchman, that's on Facebook all the time. I thought it was some type of new watch. realistically. And I started reading more about it. And then just, like on WebMD and stuff, they talked about the success rate of the Watchman. But I just did more research, just reaching out. You got to, and especially now, and with other things that I've seen come up with friends and family, you definitely got to do research, whether it's your heart or whatever. You just
Brad, you mentioned the conference, which I agree with you is a very good conference. It's very comprehensive, and that is the Dallas conference. It's the Get in Rhythm, Stay in Rhythm conference. It's held once a year. We just did it again a few weeks ago, or maybe it was a month ago. It was in person until COVID, and now it's through the web. But it's been a good conference on the web too.
Actually, I attended the one this year as well, just pretty much to support you for the most part, and try to answer questions, that people that were even considering. And the biggest question is well, what's the risk? Well, for me, staying on the meds is more of a risk than having your procedure done. And it's just your procedure. That's just basically what it is. It's a procedure. It's, for me, I went in, I was reassured, I had the utmost care from everyone in the hospital, all your staff. I can't tell you, and even the people watching this, I can't tell you the utmost respect that I have for all of his staff and the hospital staff as well. And even basically because of the pandemic and stuff, how careful they were with everything and reassured me with everything and constantly making sure everything's okay. So,
That site is stopafib.org. Other sites that people may be interested in, there is a Facebook blog. It's called Wolf Minimaze. That has some interesting comments on it. Wolf Minimaze site on Facebook. Another one is wolfminimaze.com. Now, Brad, did you ever go to that website? Was started by one of my patients years ago, wolfminimaze.com.
No, I hadn't seen any of that until the afib.org webinar. And then I started, of course, when I Googled you're at the top of the Google. It talks, Dr. Wolf Minimaze, you're right at the top of the list there. And that's when I started looking at that and got your email address and made that initial contact with you.
What do you think about the Facebook Wolf Minimaze? Have you been on that?
I have not, but I will. I'll get on there and take a look at it.
Yeah. Let's see. Let's take a few more questions here before we wrap this up. Try to get to the questions. Chronic cough with clear chest X-ray, clear endoscopy, cleared by ENT. Could it be related to arrhythmias? Well, it's a very good question.
Yeah. Let me comment on that. Okay.
Yeah.
For 3 years, from 2017, the summer of 2017, I had that cough. I went in because I thought maybe I had pneumonia, and they did a chest X-ray. Oh, your lungs are great. Your heart's fine. Your heart's not enlarged. Over and over and over. And as a matter of fact, during the whole process of that year of attempted ablations, I would be on these blood thinners. And then I would, 2 weeks before I would go in for my scan, shortly before, my cough would stop. I mean, I could tell when I was basically in AFib. Part of that AFib part to me was that cough. And it's funny because that's the first time, and I have asked and asked and asked. That's the first time I've heard anybody else talk about that. So yes, for that person that asked that question, definitely.
How about
like
now?
No, I have not had that at all. No.
And I'm sorry, I interrupted you. You feel like what?
I said, when you have that cough, you feel like that that mucus is basically lodged in your lungs, and you're trying to clear that clear. And sometimes it'd be clear, sometimes, you know, it would be like you had a bad chest cold. But no, I can't tell you how many times I went in and had a chest x-ray because of that cough, because I'd had
Great.
pneumonia back in 2003, 2002. And so, and I knew what that felt like. But anyway, that's that question. That's a great question.
Yeah.
Whoever asked that question.
And a great response too.
So,
Now, there is one other thing that could have been done at that point in your workup, and that was to put the link in, because the other part of the answer to that person is, if you think it might be arrhythmia, a lot of patients will go to the ER, and by the time they get to the ER, their arrhythmia is gone. Their EKG is normal. But there are many patients I put the link in because we weren't sure. And sometimes it's gone 30 days, 40 days, 50 days, but sure enough, then we see it, there's the AFib. And you'd never catch that by going to the ER. So in some cases, we put the link in before we do anything to see if we can prove that they are having AFib episodes. A couple more questions to wrap this up. How far out are you booking procedures now? How long to get an initial appointment? Well, initial appointment's very quick because I do mostly virtual visits. I've been doing telephone visits for 15 years because I see patients from all over the country and other countries. And I've always tried to make the patient only come to where I'm working one time, one visit. So virtual visits can be set up within a week or two. And it's a 45-minute visit. And we go over your history in great detail. I went to Indiana University School of Medicine, and they push the history very hard. And I've learned that if you just listen to patients long enough, they'll probably tell you what their issue is. So it's not a 5-minute interview. It's a up to 45-minute interview. And we talk about your history, and then what studies you've had done, then what your options are, and what my recommendation is. And that can be set up usually within a week or so. I usually do these consultations on Tuesday and Thursday. As far as when are we doing procedures now, my nurse who's on the phone all day, every day, she's great. Kimberly.
she is great. Kimberly.
Thank you.
She is
Thank
great.
Uh-oh, now she's going to ask for a raise.
Yeah,
But
well,
Kimberly,
that's okay. She deserves it.
Kimberly is telling me that she's scheduling cases now for between Thanksgiving and Christmas. So we're a little bit further out, of course, because of COVID, but we're getting them done. Well, now that while I answered those questions, we got more. Can a link be implanted with an ICD if the insurance will cover the link? Absolutely. The insurance will cover it. We've done that. The link is great because I see any arrhythmia for 4 years. So the answer is yes. What about the recall the link to announced July 2021? Should we be concerned? Not at all. That was a temporary issue. It's fixed. We went back to putting in the link 1 for maybe 30 days and then back to link 2. The nice thing about link 2 is it can link to your cell phone and you don't have to have the bedside piece. Now, Brad, I'm not sure which one you have.
I have the cell phone link, definitely.
Okay.
Yes.
And the link will only send a signal a couple feet. That's it. That's why the battery lasts for 4 or 5 years. So it'll send it to your cell phone. Your cell phone finds the nearest cell tower. The link 1 did not have the cell phone option. It only would link to a bedside device that would download in the middle of the night. So it never was a real problem. It was an abundance of caution from Medtronic, but it's fine. And there's one other question I don't think I can answer because I'm not too familiar with it. So I'd have to have more information. We went way over 45 minutes, Brad. I hope you didn't mind. You've been a great guest. You've been a great guest.
I want to make one more comment. Okay,
Yeah.
so when you go down, the mindset is, oh, I'm going down to have this procedure done, it's all medical, it's all medical. It is not. That whole process from day one, and after going through the procedure and you're out of the hospital, and there's so much to see down in Houston, literally in your area around that hospital. The food down there, there's so many different types of food to try. And it just it turned out more of like a vacation for the most
Medical
part.
vacation, huh?
Exactly. So
That's a good
those
point.
that are listening, don't just it's a 10-day trip. You're down there. First 2 days are basically the testing. Third day, you're doing your procedure. 2-3 days later, you're out. And I mean, and the whole onset is you've got to walk. It's all about walking and keeping and having a positive attitude. I mean, it's like with anything else, you're going to feel aches and pains and twitches and this and that, and you're thinking in your mind, oh, but you can't go there. You just because on a daily basis you get stronger and stronger, and I just can't tell you how good I feel, literally. So,
Well, you also answered some great questions. And I asked you before we started, would you mind if anybody wanted to contact you by email? And you said it would be all right, but maybe you should give them the email then if they want to contact you.
you bet. So if you're listening up, it's B as in boy, glass, GLASS 220 at gmail.com.
And
Pretty
say
easy.
that again slowly.
Sure. B glass 220 at gmail.com. So B as in boy, GLASS 220 at gmail.com.
Brad, thanks again for joining us. It was a great presentation. You're a natural at this. I want to thank George and Fernando, our producers, and of course, our leader, Dr. Lumsden, the fearless Dr. Lumsden, for setting up these DeBakey CV live. We will be live again in a month. It's the first Tuesday of next month at 5 p.m. Central Time. Until then, I hope you have a regular rhythm. And if you don't, you can contact us. I didn't give this number out before, but it's 713-441-9342. That's Kimberly's number, 713-441-9342. Or you can go to wolfminimaze.com. That's WOLF, Wolf Mini, like little, and then maze, like a maze, wolfminimaze.com. And there's also a way to email me directly from there. Or you can also go to the Facebook site, Wolf Minimaze. It's a chat room called Wolf Minimaze. Those are all options for you. Brad, thanks a lot. Thanks everybody for listening. We'll see you again next month. Bye-bye.